So my introduction is as a general introduction about how I think about aging and how I think about mobility. And I have no commercial conflict of interest, not whatsoever, not only related to this discussion, but none of them. So I think that in this meeting, saying that the population is aging, it's almost an oxymoron, because we're coming here exactly for this reason. But I think that this idea that there is a cross that is occurring just now about the people that are under the age of 5 and the people that are becoming 65 and over is a milestone in history. And I want you to think about this is the first time that in history this is occurring anywhere in the world. So we start experiencing something that we have never experienced before. And so we need to be prepared for that, but we also need to prepare for things that will happen that are completely unexpected. Oh, sorry. So, you know, how do we got here? I think that we got here through the decline in mortality rate occurred because of the decline of cardiovascular mortality and cancer mortality. But again, I was talking to somebody from, you know, one important magazine in the United States, and was asking, what do we expect for the future? And my answer was, expect the unexpected, because we don't know whether the projection that we're having now in terms of longevity will be true. And just as an example, I show you that while, you know, the mortality is declining and life expectancy is increasing all around the world, in the class of people that are 45 to 54, actually the mortality in the United States is increasing and the life expectancy is declining. So we know what are the reasons, at least in part, not completely. And so, and for example, we will not know what will be the effect of the pandemic, not only in terms of the mortality that is already, you know, affecting the mortality curve, but in terms of the long-term consequence, so we do not know yet. And so I think that we need to prepare for the unexpected. So what are the pillars of healthy aging? To me, I try to summarize them here. Cognitive vitality and avoiding cognitive decline, social engagement, you know, having a good use of healthcare resources that are available to us, avoiding injury, maintaining physical motility and activity, and then maintaining good mood and vitality. But if I had to make a selection among them, maintaining mobility and physical function and maintaining cognitive function will be the two that I think are the most important, because the other come as consequences. So we know that the prevalence of mobility limitation increase with aging, and we could also summarize the entire arch of the aging process, you know, from birth to death, as something that fast and rapidly we increase in mobility, then we pass a period of our life where our mobility remains stable, and then there is the decline, and this decline may be substantially different and heterogeneous between different people, with the strong possibility that we're now using the entire potential that is inscribed in our genome, and we can do better than we can do now at the population level. That is another way of looking at this. The most important and relevant measure of mobility is certainly walking speed. These are data across multiple studies in the world and from the Baltimore Longitudinal Study of Aging, showing that there is an increase in mobility that occurs rapidly. And believe it or not, you know, it's almost maximized in the 10 to 15 years of life, the relative stability with small decline, and then accelerated decline. And this curve occurs both in men and in women. In this period of life, the maintaining mobility is the strongest predictor of mortality. There is no biological measure that we know about that is as powerful as losing mobility as a predictor of mortality. So when people talk to me about biomarker, I say biomarker are for these people because in the geriatric population, doing a good geriatric assessment and measuring walking speed will give you all the prognostic power that you want. So I'm going to skip this. You know, this concept that mobility is so important, you know, was limited to the geriatric people, the people that were studying all the, you know, the older population. And it had not been received very strongly by the general community of physicians and from the internal medicine. But only recently, people realized that of the power of this measure. So this is a landmark paper from Nature, from JAMA, and where Stephanie Studensky demonstrated that a simple measure of walking speed that you can do in 3 minutes without any sophisticated tool, without having to analyze sophisticated data, will give you a very strong prognostic power. And she showed that across multiple studies, including our Italian and Chianti study. That is important because remember that in the horizon of internal medicine, there are 300 pages on cancer, and there is 1 line of walking speed. And we know that walking speed is the predictor of mortality that is stronger than having a malignant cancer. So we need to study what is the mechanism that explains this association. This is the proof of that, data from the Chianti study, that we measure a baseline, we measure walking speed, and then we did a very intensive clinical examination. And this is we divided the walking speed in quintiles, and the lowest quintile is walking at less than 0.8 meters per second, okay? And we found that the mortality, independent of age, of those that were walking at less than 0.8 meters per second was worse than having a diagnosis of malignant cancer. And because I always do that, I want to show what 0.8 meters per second is. 0.8 meters per second is walking like this. How many of your patients, how many of the people that you see in the ambulatory are walking at this speed? I think that it's such a generalized and complete and comprehensive measure of mobility that we need to do it often and often as possible in our patients. So how do we link the aging process and this risk of mortality to mobility? So there are basically 4 domains that affect mobility. These 4 domains are the change in body composition, especially at the level of the muscle. There is a neurological control and neuroplasticity that, power without control doesn't mean anything, so that the general control. And then in order to walk, you need energy. So the energetic, the capacity of your mitochondria to generate the energy for contraction is important. And then you need to have stability because you cannot really walk without maintaining the balance. So when we measure and we assess mobility, we need to make sure that these 4 components are integral. If they're not, we know how to guide our intervention. There's also an important issue of what measure we need to implement to study mobility, and that is the way myself and my group think when we do that. So we think in terms of our goal is to maximize the functional aging, that is mobility and cognitive function. But at the same time, to do that, we need to understand what the underneath phenotypes, such as muscle strength, joint function, brain function, and this is strongly influenced by biological measures. And so why we intervene with physical therapy on mobility, we also need to understand that the origin of mobility has a molecular and a cellular level. And that is important because knowing aging, we saw that aging is the ratio between damage accumulation and resilience strategies. And there is a discrepancy in time between the molecular damage and the emergence of the phenotype of reduced mobility. So at least theoretically, we should be able to study mobility before the impairment of mobility really occurs. Because you will see that there is a decline in the integrity of the system important for mobility at the time when this system already compensated. And if you do that, you have a window of opportunity to be a lot more effective than you are, when almost the mobility is already implemented. And it's really an experience of everybody that really working on all the people and improving mobility is very challenging, and most of the time, it's not really long-lasting. So we see them coming back to our clinic with the same problem that we discharged them from. Today, we have 3 fantastic talks that are talking about mobility. Eva Topinkova will talk about uncovering the major determinant behind the decline in mobility. Since 2005, was the head of the Department of Geriatric, first faculty in medicine in Prague, and chair of Geriatric Medicine Department of the General Faculty Hospital in Prague. I will not spend a lot of time to praise an incredible career and somebody with a lot of experience, publication, and I'm looking forward to listen to her presentation. Then we'll have Joseph Vigna. They will talk about nutrition and how important of the interface between nutrition and physical activity on mobility. He is professor of physiology at the University of Valencia. Again, an incredible scientist that everybody knows. And I think that his insight into the theory of free radical and biology and medicine, to me, represent a milestone that we need also to know in our field. And then finally, the friend of mine, Nicola Veronese, is an emerging scientist, somebody that is younger but has already done a lot of work in this area, and he will talk about pain, something that we don't think very often about, but it's really one of the most important origins of reclining mobility in other populations alone, especially when in combination with other multimorbidity, its effect can be incredibly strong. He's a certified trained geriatrician, currently working as senior researcher in geriatric at University of Palermo, Italy, and I'm looking forward to his presentation.